Welcome to the explainer. So let's talk about the knee joint, right? It can honestly feel like this giant, intimidating puzzle, just this massive overlap of ligaments, tendons, and cartilage. But here's the thing. Point-of-care ultrasound offers a surprisingly easy way to solve that puzzle, and you can do it right at the bedside. Let's look at how we can use the ultrasound probe to get honestly unparalleled real-time diagnostic clarity. Let's get into it.
Okay, let's dive into our clinical roadmap. We're going to cover 1. Anatomy and preparation, 2. The 6-step knee exam, 3. Common ultrasound pitfalls, 4. Major knee pathologies, and 5. Guided knee procedures.
Section 1. Anatomy and preparation, foundational knowledge.
Now, everything really starts with 3 main bony structures: the distal femur, the proximal tibia, and the patella, which just glides right in its groove. Powering all that movement, you've got your extensor muscles on the front of the thigh, that's the quadriceps group, and your flexors on the back, like the hamstrings, gastrocnemius, and the popliteus. And for stability, that comes from your key ligaments. You've got the lateral and medial collateral ligaments on the sides, plus the deep anterior and posterior cruciate ligaments. Finally, you have your built-in shock absorbers, the O-shaped lateral meniscus and the C-shaped medial meniscus, and the whole shebang is surrounded by lubricating bursa and highly vascularized fat pads.
Now, knowing the anatomy is only half the battle, right? Your setup literally dictates your image quality. You're going to want a high-frequency linear probe, and make sure it's set to the musculoskeletal or MSK preset. For positioning, keep your patient supine with their knee flexed just slightly, between 20 to 30 degrees. Why? Well, because this slight flexion tightly stretches those extensor tendons across the joint. It removes any slack and sets you up for a highly successful scan. The only exception here is when you're looking at the femoral trochlea. For that, you actually want 90 degrees of flexion. And for the posterior exam, you simply flip them prone with their knees fully extended.
Section 2. The 6-step knee exam, systematic scanning.
To really master this, we are going to follow a smooth cranial to caudal flow. We start at the top front with the suprapatellar view, slide straight down to the prepatellar and infrapatellar views, then we shift to the lateral and medial sides, and finally we wrap the whole thing up by checking the posterior view.
Let's break down those anterior maneuvers first. With your probe in a longitudinal orientation, so the indicator pointed towards the patient's head, you begin suprapatellar. Right here, you fan through the quadriceps tendon and the suprapatellar recess sitting just below it. Then, sliding straight down to the prepatellar view, you're going to check the prepatellar bursa and the top of the patellar tendon. Finally, moving into the infrapatellar view, you just sweep through the entire patellar tendon all the way down to where it inserts on the tibia. You're looking for consistent echogenicity here, while also keeping an eye on Hoffa's fat pad, which sits deep to the tendon.
Moving over to the sides, you'll notice how really subtle positioning changes basically unlock the anatomy. Take the lateral view. A slight internal rotation of the leg helps you spot the lateral meniscus, which looks exactly like a little hypercoic triangle right alongside the LCL and IT band. On the flip side, for the medial view, slight external hip rotation opens up the medial meniscus and the MCL. Just be careful not to apply varus force. Oh, and here's a massive pro tip from the source material. Definitely use your machine's zoom function and chroma maps to spot those tiny hypoechoic fissures in the meniscus. It makes a huge difference.
To wrap up our 6-step exam, we flip the patient prone to interrogate the popliteal fossa on the posterior knee. This time, you want the probe indicator pointed to the patient's left. Deep down, you are going to identify the anechoic popliteal artery. Right next to it is the popliteal vein, and definitely make sure it's compressible, just to rule out a clot. Overlying those vessels, you'll see the medial gastrocnemius muscle. Throwing on color Doppler here is a really fantastic way to further characterize that arterial flow.
Section 3. Common ultrasound pitfalls, avoiding errors.
So picture this. It's a super frustrating scenario. You complete your scan, but your diagnosis just doesn't match the clinical reality. So what actually causes a false positive? Or what makes you completely miss an effusion that is literally sitting right there? Let's take a look at some of the mechanical errors that can totally derail an accurate diagnosis.
The biggest culprits? Heavy-handedness and a lack of gel. Seriously, if you apply too much probe pressure, you physically displace the fluid, which completely hides a prepatellar bursa effusion. Secondly, keep in mind the knee is a highly irregular, bony joint. If you use too little gel, you're going to create these acoustic dead zones. Generous gel application is an absolute necessity to maintain a clear viewing window over those bony prominences, without having to smash down into the patient's skin.
So the really crucial point here is understanding anisotropy. Because the knee is so curved, a simple accidental tilt of your wrist means the ultrasound beam isn't hitting the tendon at a perfect 90-degree angle. And when that happens, the sound waves basically just bounce away instead of reflecting back to the probe. This creates a dark, hypoechoic area on your screen. This specific artifact frequently fakes out clinicians because it mimics a tendon tear or a cyst. The fix? Always fan your probe to ensure you stay perfectly perpendicular.
Section 4. Major knee pathologies. Diagnosing injuries.
Now for the detective work. When we're looking at traumatic and overuse injuries, ultrasound is amazing at clearly visualizing structural discontinuities. For instance, an MCL or LCL injury will present as a thickened ligament with a distinct hypoechoic interruption right in the fibers. Jumper's knee or patellar tendinopathy is going to show up as an enlarged hypoechoic tendon, usually with increased blood flow on Doppler. A patellar fracture, that gives you a very visibly disrupted bone cortex and a hypoechoic hematoma. In a meniscus tear, you'll see irregular edges in these dark anechoic areas right inside that usually solid meniscus triangle.
Let's see how this builds when we evaluate joint effusions. A simple joint effusion is purely black. It's completely anechoic on the screen. There are zero internal echoes. It's just clear, serous fluid caused by basic inflammation. But a complex joint effusion, that tells a much more dangerous clinical story. It has a heterogeneous appearance. If you compress it and you actually see swirling internal echoes, you are likely looking at blood, hemarthrosis, or even a fat fluid level known as lipohemarthrosis, and that is a massive red flag for an occult intra-articular fracture.
And speaking of lipohemarthrosis, check this out. Ultrasound boasts a massive 97% sensitivity for detecting this fat fluid layering in the suprapatellar bursa. To put that into perspective for you, plain radiographs only catch it about 55% of the time. Point-of-care ultrasound absolutely eclipses standard X-rays for this specific trauma finding. It's a total game changer.
And this brilliantly illustrates gout. This is known as the double contour sign. So normally, you just see the deep, bright white, hyperechoic line of the subchondral bone. But in gout, microscopic monosodium urate crystals actually invade and deposit themselves right on top of the cartilage. This creates a second, superficial hyperechoic line directly parallel to the bone. It's an absolutely incredible visual confirmation of a crystal arthritis flare-up. Another really common pathology you'll see is the Baker's cyst. If a patient has secondary joint space inflammation, say from osteoarthritis or maybe a meniscus tear, that fluid can physically communicate with the popliteal bursa in the back of the knee. It pools into an anechoic or hypoechoic pocket right between the semimembranosus and the medial head of the gastrocnemius tendon. If it ruptures, that fluid tracks all the way down into the calf, totally mimicking a DVT. So definitely something to watch out for.
Section 5. Ultrasound-Guided knee procedures. Therapeutic action.
Whether you're doing a joint aspiration, an arthrocentesis, or a therapeutic injection, there is a highly structured, basically foolproof method you want to follow. Step 1, find your target in the long axis view. Step 2, rotate the probe 90 degrees so you are in a short axis view, making sure the indicator is to the patient's right. Step 3, freeze the image on your machine and literally measure the depth from the skin down to the target. And Step 4, insert your needle from lateral to medial using a flat, in-plane approach. The true advantage here is that in-plane approach. By aligning your needle perfectly parallel with the length of the ultrasound probe, you ensure continuous visualization of the entire needle shaft and the tip as it advances toward the target. You see exactly where you are going at all times, which drastically reduces the risk of collateral tissue damage. This kind of real-time visual feedback is exactly what makes modern point-of-care ultrasound an absolute game-changer for procedural safety.
So, we've covered the anatomy, the 6-step exam, the pitfalls, the pathologies, and the procedures. I really want to leave you with this final thought. With bedside ultrasound offering unparalleled real-time clarity and immediate therapeutic guidance, is your default reliance on MRI actually slowing down your clinical impact? Think about it. It might be time to upgrade your practice, grab that linear probe, and integrate these skills immediately. Thanks for joining me on this explainer, and happy scanning!